Thank you for joining us today. I want to welcome everyone to the STS Early Career Webinar Series. Today's webinar is titled Early Career Journey, Growing and Learning from Bad Outcomes. Please note that this webinar is being recorded and will be available tomorrow morning on the STS website and STS YouTube channel. We invite you to become a member of STS if you're not one already. You'll enjoy a variety of benefits and opportunities to help you grow professionally, plus discounts on educational offerings and resources designed specifically for early career surgeons. One of the most important things you can do is partner with an organization that will help you broaden your skills, connect with peers and mentors, and take care of your health and well-being. Learn more at sts.org/membership or use the QR code on your screen. Early career surgeons are also encouraged to visit the Early Career Hub on sts.org for access to podcasts, blogs, videos, publications, and other resources designed specifically for surgeons in the early stages of their career. Dr. Mitzman, would you like to say a few words about STS membership?
Yes, thank you, Beth. First, I want to thank Beth and the rest of the STS crew for all of their effort in developing these early career journey webinars. I hope everyone out there understands that our organization would not function without this wonderful team. As early career surgeons, to me, membership in STS is essential. It opens the door to amazing networking with your colleagues, opportunities for support and growth as you build your practice, and the ability to affect change in cardiothoracic surgery at the national level. Also, your membership supports events and webinars like this. If you aren't a member, please consider signing up. We hope to see you all get involved. Now back over to Beth, and let's get this webinar going.
Thank you, Dr. Mitzman. At this time, I am pleased to introduce tonight's moderator, Dr. Reilly Hobbs. Welcome, and let me turn it over to you.
Hello, thank you everybody for tuning in tonight. I'd like to start by just thanking Brian, who's chairing the STS education workforce, and he's just done a great job. And let me start my video. And he's been a great advocate for the STS members. But really, our focus is trying to promote and support early career CT surgeons, and we thought the topic of dealing with unanticipated outcomes would be really worthwhile. We have three really great speakers, and without further ado, I'd like to introduce Dr. Ian Bostock. Dr. Bostock is an assistant professor of surgery at the Division of Cardiothoracic Surgery at MUSC. He completed his general surgery training at Dartmouth and then his thoracic surgery training at MD Anderson. He's going to talk to us tonight about what we can learn from other disciplines when it is regard to dealing with difficult situations.
Thank you so much, Dr. Hobbs. Let me share my screen. Good evening, everybody. So more than learning from other disciplines, I wanted to talk about lessons in what I think I can label as courage and vulnerability from my own experience. So that is my disclosure. This is mostly self-experience and what I've been going through in the past few years. Transitioning into practice, I'm originally from Mexico City, where I attended Anáhuac University, and then I did my intern year in Boston. Then I did my training at Dartmouth for general surgery, where I had a significant amount of mentorship towards thoracic surgery, specifically general thoracic surgery. I did my fellowship at MD Anderson Cancer Center, and then I took a job at the Medical University of South Carolina in 2021. As I've just beginning my third year in practice, summarizing my last 2 years, I would certainly agree with what everybody told me to expect about being an early career surgeon as an emotional roller coaster. There are certainly days where you think that you're on top of the world and everything is working out well, and days where it certainly isn't. And every case seems like it's more difficult when you're starting out. I kind of kept comparing myself to the cases that I was doing in fellowship, and it didn't make sense to me why I was struggling a lot more than I thought I was before, which starts bringing in an inner narrative that can be very destructive. Certainly the questions, am I cut out for this? Should I be doing this case? Should I be just doing the simple cases and handling the difficult cases over to my partners? Do I feel supported in case I run into trouble or I do need to ask a question? And those are very important areas that are going to really help you grow past those first few years in a safe way that keeps patients safe, but also keeps you safe and keeps you feeling well as a provider and as a surgeon. And these are things that people that are looking at jobs in the near future should really focus on. Do I have the mechanisms in place in this position I'm considering that's going to be real? But also, I started thinking about you. I used to think that I was a very kind of even keel, able to tolerate stress. I think I did well during my training, but when I transitioned into being an attending, that really changed for me. And I started feeling these levels of anxiety and irritability that were new to me. I was used to coping with stress really well. And now suddenly when I was on the driver's seat, things felt different. And the coping mechanisms that were working before probably weren't working at the time. So I had to start thinking about what other things do I need to do to ensure that I am healthy as I transition into practice. As I said, having your name on the chart really added an additional layer of intensity to how I was feeling. You know, in this field, CT surgery is certainly a very demanding field. And when the highs are high, that's great, but the lows are really subterranean. And you know, for every bad outcome I've had in the past 2 years, you think you'd had I thought I would have a linear experience through my grief, but let's say the grief for the patient, but also the grief for the outcome, the grief for whether I should have done better in a situation, the grief for my skill set, whatever you want to name it. You think you'd go through denial, anger, depression, bargaining, and acceptance, but in reality, I think you go back and forth until you finally reach that acceptance. And that time frame, I feel like at the beginning of my first 2 years was really variable, and now at least I think I'm able to reach that acceptance a little bit faster, or with more ease. I think I kind of understand that sometimes failure comes with the territory, but it's certainly difficult. But I also realized during this time that whenever things would go bad or have gone bad, I had a very critical narrative in my head. We're all high achieving people. We all want to do the best that we can for our patients, but I tended to be very critical of myself. And I noticed that by being so, I was destroying my kind of inner impulse to do better. And I thought that I was going to get into a situation in which I would avoid challenges because they would be difficult. And I started to kind of feel threatened by the situation until I decided to kind of switch my mindset. And in this famous growth mindset, I really started looking into it more, in which you really view intelligence as something that can be developed, skill as something that continuously develops over time. It's not a static thing. You embrace challenges and you can train your brain to react in different situations, good or bad, so that you're always protecting your inner narrative and yourself. There's an effort as a part of the path to mastery, and you can learn from feedback from yourself and from the environment. And instead of comparing yourself to others, you're inspired by their success. And I would say that as an early career surgeon, I really encourage people to avoid comparing oneself to others. I think with social media, with the way our academic works, you're constantly comparing yourself to others, and it can make your experience feel like it's less so than anybody else's, when in fact you're just in the path that you should be, and you're probably doing the best you can with what you got, and that needs to be accepted so that you can move on and take advantage of your opportunities. When you're seeking mentorship, I think mentors come in all shapes, sizes, and situations. So sometimes you want advice, sometimes you actually need mentorship, sometimes you just need sponsorship. And some people can give you one, some people can give you all of it, but most, in my experience, not everybody can do all of those things. So I sometimes, when I had a bad outcome, I would go to some of my colleagues or peers or partners, and then I realized that they weren't giving me what I needed. So one of the things that like now I think it's like a question as a mentor should be, do you want me to listen to you, or do you want me to tell you what to do? Because sometimes you just need someone to listen to you so that you can take it off your chest and digest what has happened. But sometimes you want them to tell you what to do. Sometimes you want somebody to take over the case. But is that detrimental to your growth? I think so. So sometimes you just need the right support. But now, as I transitioned in my first 2 years, I kind of have entered this new phase of my training. And then I think that I realized that has happened to me in the past 2 years is that for my training, during my training, I focused on becoming the best surgeon I could be. But I realized that my personal growth as a human being was really delayed. So I went through this epiphany where I'm 35 years old, but I felt in my personal life like I was 26. I had so many things that I forgot or wasn't paying attention to because I was so focused in training and doing all of the things that the rat race to be a surgeon it entailed, that I forgot a lot of things about myself. So I refocused on eating well, my health, my physical health, exercising more. I started listening to podcasts and reading and having fun and doing other things outside of work that are also going to keep you safe and happy. And then this idea of a cognitive therapy from surgeons, as I started reading more and more things about how to deal with the stress and irritability that I had noticed in myself. You really need to train yourself to react towards stress. Watch the tone in your voice, your body language, the way you communicate with people. Make sure the team in your operating room knows and knows you appreciate their hard work and feel like they can communicate with you. And I feel like a perfect the lesson is to lead with vulnerability in these situations. There's an author, Brene Brown, that I have found that she writes really interesting things that could be reflected as a surgeon, and you can really reflect in them as a surgeon. And she says that vulnerability is not oversharing, it's sharing with people who have earned the right to hear our stories and our experiences. And that really helps you build relationships with your team and your coworkers, and they make you better as a leader, which is anyone who takes responsibility for finding the potential in people and processes and who has the courage to develop that potential. I really recommend her work. I think it's been a good way to help me develop myself as a leader in the operating room over this past 2 years. So she says that through vulnerability, we find compassion to be kind with ourselves and others. We find empathy. We find the courage to be imperfect and to make mistakes, and to remain authentic to who we are. And that's how we're going to take care of our patients in the best way possible, remaining human and remaining vulnerable. Thank you, everybody.
Thank you so much, Ian. Just a quick housekeeping point. If anyone has questions, they can use the question and answer panel below. We've saved some time for the end of the talks to answer any questions that could come up, or you can use the chat if that's useful to you. Next, we have Dr. Stephen Yang, who probably doesn't need any formal introduction. He's a professor of surgery and medical oncology at Johns Hopkins. He's the first recipient of the Arthur and Patricia Medell Professorship, and he serves on the American Board of Thoracic Surgery and is heavily involved in medical education, and he serves on a number of national and international committees. He's going to talk with us today about dealing with some of the challenges of litigation in your early practice.
Great. Well, thanks, Dr. Hobbs, for that very kind introduction. And again, I'd like to thank everybody for coming on this evening or wherever you are in the world to sort of improve yourself. Also, thanks to the leadership, Beth, Doctors Antonoff and Mitzman for their work on the committee and allowing me to present this very indubitable topic of lawsuits. We always worry about it. I think we sort of think about it. So I hope I don't get sued, but again, we can't dwell on it, and hopefully we'll teach a little bit of what I've learned. It's hard to, we don't learn this. Unfortunately, you're not taught this during your residency or training. Unfortunately, it's sort of a bit on the job training. So my disclosures are that I don't like lawyers. I've operated on them, but I really get wiggy when I see a lawyer, and these cases really come out of left field. Sort of they surprise you. So I've been at Hopkins for 30 years. I've done almost 10,000 cases, and luckily I've only had 4 suits brought against me, and I don't know whether I hopefully did a good job, but I sort of impart a little bit of experience, much like Dr. Bostock said. This is not something that I go out and lecture on. There's not a lot of references out there, so I'm just sort of imparting a little bit of experience. So I thought I'd start out with a quick story. So I said I've had 4 cases. Probably the most troublesome one. About 15 years ago, I had a nurse practitioner come from Arizona with a lung nodule, and she had PET positive mediastinal nodes. And, usual thing, you do a MED, was negative, thought it might be fungus, but the fungus was negative. So one of the rare times I don't do a mediastinoscopy with a lung resection. She was a smoker. So obviously the right upper lobe lung lesion was still on the table as potential cancer. We took the lobe out, and it was, burnt out coccidio. She did great, no problems. Go back now, and you have 10 years now. So 5 years ago, I get this suit from her. I said, well, that's 10 years ago. And she did fine, but she never came back to see me. And so she said that, I didn't tell her properly about the mediastinoscopy results, that had she known that this was really truly a fungus, then she wouldn't have had the lobectomy. And so, she filed a claim. She ended up taking me to court, the only time that I've actually had to go to court. So that was a difficult experience, to say the least. And I'll give you the results a little bit later, so you can sort of hang on for the cliffhanger. So basically what I'm just going to talk about for the next few minutes, a little bit about background data. So again, there's not a whole lot of information for cardiothoracic surgeons, and I pulled out what I could. What steps could happen to you, and then what to do if a claim is made against you, and how to make a stand. I pulled out some references here, some very brief reading. So there's one about 20 years old, but I think it's still okay as an introduction to medical malpractice in the United States, and a little more recent one in Stat Pearls, and actually outlines some things very well. So what can happen when there's a claim by a patient? So usually it just starts with a complaint. So maybe the family or the patient calls you just to discuss a correction of a problem. It can escalate to charge detail, alleged injury or failure, and then it can actually go out on public notice. Then there's this discovery phase. So you might get interrogated a little bit more. The lawyers may come to talk to you. The plaintiff's lawyer may come talk to you. There's depositions, there's expert witnesses. So now, there's a lot of noise going on with a potential court case. So it's decided it's going to go to trial, and so hopefully it'll get settled. That's really the best thing, is that there's a lot of pretrial discussion, and then people weigh the odds of whether they can win or not, and then they settle the suit. However, if they don't, then it actually goes to trial, and then you put up in front of a number of jurors, and then there's a verdict like any other trial. So whether it's good or bad, then there can be appeal by either side. So it's not a retrial, but just a review of the trial by an independent judge, and then they make another decision. And obviously this can go on and on and on through re-appeals. One of my good friends here at Hopkins, Dr. Marty Macri, published in the British Medical Journal 2016, and he looked at actually the number 3 cause of deaths in the United States is actually from medical error. So this is the basis of what potential lawsuits can come in. And then when you look at the types of physicians who are sued, so number 1 are OBGYN, number 2 are general surgeons, and then number 3 are the surgical subspecialties, plastics, neurosurgery, and cardiothoracic surgery. So we're lumped in this category. So about 50% of us have been sued, and then 25% of it have actually been sued more than twice. And I think the record number is a cardiac surgeon up in the New England area who's been sued 21 times. I think I read that was the record so far. And so if we look at some of the malpractice risks, according to physician specialty, and this was published about 12 years ago in the NEJM, If we look at the number of claims annually, so cardiothoracic surgeons on average, about 20% will have a claim filed against us in any 1 year. And if we look at the payments to the plaintiff, it's about 150,000. So the median is both 150,000 and the mean is that. So we're not on the high end of the scale, but we're not on the low end of the scale for payments, but we're right in the middle. So if you ever get a claim, so what's the chances of that you'll get the verdict? So there's not a lot of data in cardiothoracic surgery. Frank Selke published this just last year. He presented this, I believe, at the STS and just looked at the litigations and cabbages. And he looked at a legal database and reviewed 211 litigations in 33 states. And if we looked at the verdict, it went to the defendants, us, the surgeons, about 70% of the time. 20% it went to the plaintiffs, and about 10% of the time it was settled before trial. But if you had an MI during that hospitalization, it was associated with a higher risk for a verdict for the plaintiff, and about 50% of these litigations had a mortality involved in it. And if we looked at the reasons for litigation for these cabbage patients, they're listed here, the things that you probably are pretty well accustomed to: failure to diagnose, procedure error, failure to obtain informed consent, failure to monitor, unable to timely treat, failure to refer. Loss of consortium means you've lost a loved one. So you've lost your parent, you've lost your daughter, you've lost somebody that you love, somebody that you relied upon for support. And then finally, the other is unnecessary surgery. Sorry. But there's other errors or mistakes that not listed in this, which are also the cause of lawsuits. So mistakes in medication, retained instruments, using improperly sanitized equipment or tools, or mistakes during childbirth, which we generally don't see, but we might see if you're a congenital heart surgeon. So what should everybody do? So again, don't panic about worrying about a lawsuit, but the first thing you should do is make sure you have professional liability insurance. Again, it's not a gimme. We all take jobs and we get contracts and we assume we have health care and we assume that we have professional liability insurance, but make sure you do. And there are two types of insurance. One is what's called an occurrence-based liability. That is, that type of coverage continues to cover patients when you have that insurance. So even after you leave, so during the time period you were treating that patient, you're still covered for that patient. The other type of liability insurance is what's called claims-based. So it covers claims only during the terms of the policy. So if you decide to leave and you get sued by a patient from your previous practice, you are not covered by that insurance. And so you may have to purchase what's called tail insurance to cover those patients after you leave. Now, I'm not going to go through the cost because there's a number of factors that go into it. It's going to be high or low depending upon these factors here. So again, I'm not really going to go into much detail about that at all. So obviously the first thing is, how do you prevent these things? Well, again, some of these things I'm going to tell you, hopefully everybody does this. You just have to practice good medicine. You know, spend a lot of time with your patients, spend time in clinic, talk to them in the hospital, see them post-op every day, visit them on the weekends, and then see them post-operatively. And for me in my practice in general thoracic surgery, I follow my patients forever if they have cancer, because I do their surveillance over time. Make sure that your patients and trainees are educated into the types of procedures. So make sure that not only the patients understand the operation, the potential complications, you know, the potential treatments afterwards, but also that your trainees understand these things. So again, sometimes they just focus on the operation, but again, in a few years, they are responsible just like you are. Document everything as soon as you can. Again, you shouldn't be in trouble with documentation. So because this can come back to haunt you later. If you get ever sued, they may ask you, are you on time with your medical records? Because they'll say, well, I'm okay. I can dictate an op note from a week ago. I remember that. But they'll say, well, doctor, do you remember what you had for lunch a week ago? I think a lot of us will say no, because we just don't remember those things. So that translates into some memory issues. We all have APPs. We use them wisely, but again, make sure that you check some critical results yourself. So if it's something that a PET scan, lung function test, echo, cardiac cath. It's really going to change your operation. Again, they can tell that to you, but make sure you check it yourself so that you know that you're doing the proper operation. And then finally, make sure all your consent forms are properly filled out, that they include all of the major potential problems that can occur during any operation. Again, I don't have to remind you about professionalism, but I'll tell you that many cases are won and lost based on professional skills. And I'll tell you a little story about this when I finish up here. Again, treat all your colleagues and providers with respect, because if you don't and you get pulled into court and they testify against you, it's going to rear its ugly head. Again, as I said, keep up with your credentials, your certification, your CME. If you ever get into a deposition, this is the first thing that the plaintiff attorney is going to ask you. When did you graduate? Did you pass your boards? How many times did it take you to pass your boards? Are you on time with your medical records? Are you on time with your CME and certification? So if you're lacking that, it's going to come back to haunt you. Again, I don't need to tell you this, but avoid using social media in your patient patient care. And then finally, if there happens to be a problem, don't modify medical records after the fact. You can always put a late entry. This is always acceptable. You always just say, I'm just changing the record because I found out something new. What happens if a bad outcome occurs? So again, make sure you're honest, that you're timely, you take responsibility, and you can't blame your trainees, because we as the attendings and the hospitals, we are responsible for our trainees. So again, if something ever happens, make sure you give them feedback. Document extensively. So if there's an issue, document every time you see the patient, document any time that you make any major changes. Again, round and see the patients more often. You don't have to overdo it and sort of hang on them all the time, but again, you need to make sure that you sort of hover over them without showing that you're too overly concerned. And then also let risk management know that there may be a potential problem. So what happens if there is a bad outcome, or you get a patient complaint, or somebody faxes to your office, they want requests of your records, and you know that something may be fishy? Well, again, notify risk management or the legal office. If there's a formal claim against you, do the same, but do not contact the family. Do not ask them why they are doing this. So again, make sure there's enough documentation in the chart. If you are named as the defendant, ask to see if the hospital can be named instead, because if you are named solely, this will influence every time you go up for renewal of your licenses or certificates, because there's always that question that's going to ask you, have you ever been sued? And even if it was a favorable verdict toward you, you always have to put this down. Again, I don't have to tell you this, but reflect sympathy. Do not admit liability or blame other people. And then this is a little bit difficult, so be careful about continuing to treat the plaintiff. You may have to get an intermediary to ask them if they still want to be seen by you, because if you just drop them automatically, it may be seen as an admission of guilt. And then finally, really try to get the hospital to settle it. You don't want to, spend a lot of time doing this, going through a lot of stress. The hospital can settle these cases, and more often than not, it's not for a lot of money. So again, the thing that we've been talking about this is sort of your personal health. I think that Dr. Bostock mentioned this, is that don't take this accusation personally. It's really just the cost of the business. And some of the lawyer websites, I've seen this. This is a business deal. It has nothing to do with you. So the things that you should do is make sure you get social support from your family, from your friends. You don't talk to them about the case, but just make sure that you get some support from them. This is one of my favorite things from Rocky. It's not about how hard you can get hit, but it's how hard you get hit and keep moving forward. So just make sure that it doesn't affect your mastery or skills, okay? Maintain your self-esteem. You need to reflect on your career sometimes. Maybe it's a time to change the way you're doing things, or maybe stop doing those types of patients. You may have to prioritize some things in your lifetime. And then I think Dr. Bostock also said is that you have to be kind to yourself. Don't beat yourself up if you get a lawsuit. Again, it is mentally damaging, but you just have to move on. So what you should not do, a checklist of things, don't don't panic. Don't take it personally. There's going to be a lot of emotions that's going to be wrapping around your head. If you want some help from support professionals, make sure you ask your legal team that it's okay to do so. As I said, don't access or alter medical records. Wait until you've been advised to. Don't talk to others. Don't talk to the plaintiff's attorney. If they ask to talk to you, make sure you get representation, and don't use your personal attorney or lawyer friends. They actually can be the worst people. So again, most surgeons are vindicated and malpractice cases rarely reach trial. Remember, it's all about compensation, not competence. You are competent. All they want is money. So really, that's what's central to the malpractice case. Your emotions will wax and wane. So seek emotional support early and often. And then finally, claims come unpredictably. As I said, I've had 4. One was a lung reduction case that, I thought they did okay, but they ended up passing away, and the family sued me. And then actually the son kept coming after me, and we had to do a restraint on him. The second was a lung transplant. I transplanted somebody with glioblastoma, and about 6 months later, it recurred in the lungs. And then all of a sudden, all of the other organs that donor went to, the heart, the liver, the kidneys, they developed glioblastoma. All those families sued me because it came back in the lungs first. So there's no rhyme or reason. And we still transplant patients who've had astrocytoma. And then, finally, it was just another, I saved this guy's life with a transplant and a lung reduction. And he sued me because he had a pressure ulcer on his backside. He was diabetic and obese. So again, they come out of nowhere. So just to give you the final on what happened to me with this lady who sued me, it was actually just sort of a comedy of errors. She got up on the stand. She contradicted herself. She got mad at her own lawyer. The lawyer was a buffoon. He couldn't get his documents to come up. And then I'll tell you what happened is that one of the jurors passed out. And so the lady, as I told you, she was a nurse practitioner. She walked out of the room. I stayed behind to help that juror out. I got the okay from the judge and also from my lawyer. I helped her up. My wife was there as well. We helped her. We called 911. She got better. And guess what? After the prosecution rested, the judge said, trial's done. There's no case here. And the reason the judge told me was because he thought that I was a very kind surgeon helping that juror out. So again, went through a lot of misery, but I learned a lot. So again, these things are just so unpredictable. So again, I want to thank the STS and the leadership for their graciousness in asking me to discuss this very difficult topic. So thank you very much.
Thank you so much, Dr. Yang, for such a great talk. That was really eye-opening. I'd like to introduce our next speaker. So this is Dr. Linda Martin. She's an associate professor and the chief of thoracic surgery at the University of Virginia. She completed general surgery training at the Universities of Minnesota and UCSF, and her thoracic surgery training was at MD Anderson Cancer Center. She also holds a postdoctorate degree in public health from the University of Texas. She's going to talk to us today about second victim syndrome.
Thank you. And by the way, I'm full professor now. Thank you very much. I just got that promotion on July 1st.
Congratulations.
Thank you. Let me get my screen up and running, and hoping you can all hear me okay. I just switched to a, oh goodness. Okay. I just switched to a different microphone. So I'm hoping that's working okay. Okay. I think we got the right screen up. All right. So my topic tonight is second victim syndrome. And this is something I've only recently been aware of in terms of the terminology here. So I wanted to start with the definition. This comes from a publication from Albert Wu, who is from the School of Public Health at Johns Hopkins University. And this came out in 2000. And I don't think it got a lot of notice at first. And now there's gazillions of papers in the last couple of years quoting this concept of second victim syndrome. And the idea is that although patients are the first and obvious victims of medical mistakes, doctors are wounded by the same errors, and they are the second victims. And, I think this rings true with many of the things we've heard about tonight. This is a diagram just to kind of better display what the idea of second victim means, that if you've got a cycle going on with a complication. The first victim is the patient, and there's some factors that may influence the likelihood of them being a victim. The second victim is the surgeon or physician, and there's other factors that might influence either the likelihood of it happening or the impact on the individual. And then the third victim is the hospital, and that includes resources, accreditation, boards, medical legal concerns, political concerns. And then there's these offshoots of how the second victim may or may not interact with other support systems or coping techniques. So just some thoughts about the culture around medical errors. And we've heard a very thorough review of that from Dr. Yang. And I think sad but true, but hospitals tend to react to every error as if it's an anomaly, that it should never have happened and it's a never event. And the default is to find somebody to blame. And that just seems to be, you know, I think about it, we all are supposed to be perfect, and anything less than perfect is failure, and there's no in between. And I don't think that's a healthy way to look at the world, but I feel like that is somewhat the environment that we function in. I have personally found that somehow when there's a bad outcome, it feels especially worse when it's an elective patient. And it gets back to that comment that Dr. Bostock made earlier about the idea of when your name is on the chart, all of a sudden things feel different. And when it's your patient that they chose to have you operate on them, and it's a planned procedure, and there's this relationship that's developed, and something doesn't go well, it feels a lot harder than if it's, say, a trauma or emergency patient, and you just happen to be the receiving physician. They came in with a problem. All you're there to do is to try to make it better, but you didn't cause it. And that somehow emotionally and mentally feels different to me. I imagine that's probably true for most people. And I actually imagine that might be why some people choose to go into trauma, but who knows? Things that can affect the physician, all of this causes tremendous amounts of anxiety, sadness, guilt, shame. These emotions are tremendously prevalent whenever there's a medical adverse event, and this adds up to psychological trauma, and in many cases, even flat out post-traumatic stress disorder. And this other vicious cycle can ensue where a medical error can facilitate and lead to burnout. And once you have some burnout going on, you're more likely to make medical errors, and the cycle will just continue on and on. Some of the other tolls on the physician, I think Steve mentioned these, this strong urge to stay scarce. When you had a bad outcome with a patient, they're now in the ICU, the last thing you want to do is walk in and round on that patient every single day. It's like opening up the wound and pouring salt into it every day for your emotions. And it's really hard, but at the same time, very important to maintain that relationship with the patient, make sure that they don't feel abandoned. The physician is often going to feel wounded. And what's very hard to measure is that physicians will frequently sort of lose their nerve and become risk averse. And it could be that, oh, they had a bad bleed from the pulmonary artery and a left upper lobe, and then they've been doing lobes for 10 years, but whenever a left upper lobe comes along, it kind of gets their pulse racing and they get extra nervous and concerned about getting into the artery again. We talked about burnout and how much this can be a factor there. And it's very frequent and common that after an adverse event, there's a tendency to want to feel numb. And whether that is by drinking or smoking or some other abusive behavior, that is a very common response to the situation and can certainly turn into a spiral into a bad place. And, you know, more seriously, there can be mental health concerns and even suicidal ideation that can be a result of a bad outcome. So who's at risk for this? I mean, really anyone can have this issue, but studies and meta-analyses have found that this is most prevalent in young surgeons and also most prevalent in females. People who are already feeling burned out or fatigued, demoralized, unrewarded are more likely to have this response to an adverse event. They're coming from a place where they're not at their best and they have less reserve, less resilience. And it's also when there's a perceived imbalance between professional and personal life and someone's really struggling with that balance, they're more likely to really be sort of beaten down by an adverse event. And just talking this over with my fiance over the weekend, we were talking about this and we were wondering how much people with imposter syndrome may be more prone to being at risk of second victim syndrome, that if you already feel like maybe you're not good enough and you don't deserve to be where you are, that an adverse event is only going to sort of perpetuate that feeling. And I feel certain that's probably the case, but I haven't read anything to substantiate my theory. I should have said this at the beginning, but I am by no means an expert on the topic. Everything I know about this, I've actually learned from my good friend, colleague, and coach, Mike Mattis, who hosts the Resilient Surgeon podcast. And I would say if you do one thing from this webinar tonight, it's that you download and listen to the Resilient Surgeon podcast interview with Hytham Kafarani. It was from the end of last year, December, and it is just an absolutely fantastic, eye-opening podcast about what is this second victim syndrome, what can we do about it, and what's the research around it. It's an incredibly educational podcast. And on the same note, I think that is what led Mike to write this article, which I believe came out in this month's JTCVS, September 2023. And it's a fantastic expert opinion essay about the second victim syndrome and what is it, what are situations that lead to it, what are some things that we can do about it. And I would say that is essentially mandatory reading for all of us. It's a very, very well written article and extremely educational. When I think about this topic of second victim syndrome, it's a lot about turning the lens away from the complication and the process and turning it onto the surgeon and the individual and saying, okay, this bad event happened, but how are you doing and how are you going to move forward from this? You get the big punch and how do you keep moving forward, like Rocky said, and finding a way to keep going and sort of self-nurturing and taking care of yourself and things. And I totally support that. I agree with it. But there's a part of me that says you can't just completely shun the blame or the mistake. You need to take some ownership of the situation and learn from it. And it reminds me of a book I was given as an intern when I made what I thought was a catastrophic mistake. And it was actually really minor in retrospect, but I was so upset that I had missed this lab test or made a mistake or hadn't communicated adequately about something. And I was, crying in the chair's office. I just felt awful. I thought I was the worst person and I was going to get fired. And he gave me this book, Forgive and Remember. And it's a lot about being compassionate towards yourself, but also trying to learn something from the situation and figuring out how you can get stronger and better and move forward. And I do think it's important to find a balance between being accountable for a mistake or an error, learning from it, and at the same time, not just destroying yourself and your career because of your grief and sort of self-hatred, if you will, from the situation. And Mike and I were exchanging some texts just yesterday about all of this. And he said he's read this book 3 or 4 times. And this was a text he sent me that I thought was really poignant, that mistakes and errors are part of the journey. And it, like this entire enterprise of life, is all about continuous, steady, and yet compassionate improvement and gaining wisdom. And then a last quote I want to leave you with is from that original article from Albert Wu. And he concluded his essay with the following statements: that his assignment for the practicing doctor, and I could say this is your other assignment from tonight, is to think back to your last mistake that harmed a patient, talk to a colleague about it, and pay attention to your colleagues' reactions and your own as you're having the conversation. What was helpful? What made it harder to have that conversation? And we have to realize that physicians will always make mistakes. The decisive factor is how will we handle them? Patient safety and physician welfare will be well served if we can be more honest about our mistakes to our patients, our colleagues, and ourselves. I think those are extremely wise words. And really, the last thing is how do we move forward with this? What I've talked about so far doesn't really tell you exactly what to do. It's more describing the problem, bringing it to light. But there's some very interesting things that came from that podcast with Mike Mattis and Hytham Kafarani. And this is work that came from Massachusetts General Hospital, that Hytham has developed these peer support groups that when there's a complication, that there's sort of a mirror image response from friends, colleagues, and even designated individuals within the department that are there to provide support. There's to stop talking about the errors in the event, but to talk about how that surgeon or that person is feeling, and to be there to listen and support without judgment. And to aid in the grieving process, really examine the feelings of the physician instead of the medical facts, and to bring some normalization to the reality that Steve just said, that we're all going to have adverse events. We're likely to get sued at some point. You know, things like these are going to happen. It's the cost of doing business. And we need not to think that we're the aberration, that we did something terrible and we're bad. We need to realize this is just part of the work that we do. And some other really good advice that comes from this idea of peer support groups and the work from Mike Mattis in his article is, sometimes what we can do as friends and colleagues is to immediately help that surgeon with patient care. If the person's completely devastated from a bad outcome, someone's got to take care of that patient, and we got to make sure that there's a person tagged that's going to be on top of things, paying attention, and helping that patient get through their recovery if they're hopefully still living. And also to think about that person's elective schedule the rest of the day or the next day, or, you know, in the short term, and maybe they need a break, maybe they need to spend some time at home, maybe they just need to get away from the situation, and that we as friends and colleagues can provide that support for people. And last, I would like to suggest a manifesto from tonight, besides the other ones I gave you, is to approach your department chairs and talk about how you could form a peer support group. But I encourage you to read the article by Mike Mattis and the interview that he did, where you're going to hear about ways to do that. I think it's going to be very healing and helpful to those who are the supporters and the supportees. And so there's growth to be had on both sides. So thanks so much for your attention, and I look forward to the panel discussion.
Thank you everyone so much for your talks. They were all fantastic. We'll move forward to some questions that we have. I was going to start with Dr. Yang. Dr. Yang, you know, we hear about risk management in a lot of different hospitals. They have risk management. And I think a wrong way of thinking, it was my way of thinking for a long time, is getting risk management involved early. Is that an admission of guilt before a patient or their family seeks kind of legal counsel regarding a bad outcome? And what's your perspective on that?
Well, risk management doesn't really mean that you've done something wrong. It's just sort of give them an alert that there might be a problem. Family doesn't know that. I mean, you're not going to tell the family, hey, listen, I'm going to talk to risk management, make sure we're okay here. But it's sometimes just a heads up, because sometimes they'll look at the chart. They'll see what's going on. They may give you some advice. Like I said, I've done it a number of times when, patients haven't done well. There's been, patient complaint or a family complaint. Just to, let them know that, well, there may be an issue. They can also talk to, especially if they've gone to, the patient complaint department, and they go different ways to file their dissatisfaction, so they can sometimes help you with that as well, and they'll sort of be the intermediary if there's a issue with the family. So it takes a little bit of judgment when you go to them. If you really think there's going to be, it could potentially be a suit, then I would go to them.
I'll just add to that. I have called risk management freely and readily here at UVA, and we have our own private sort of physician liability team. It's not a public or a national carrier, and we know them, and they're incredibly helpful. And I've called them like in real time about things, and they've given me really helpful advice about how to message things to the family, how to document, not going back and changing documentation, but how do you word things going forward. And I feel like I've learned a lot every time I've done it. And it actually is kind of healing when I talk to them. It kind of makes me feel like things are going to be okay. And so far, every time I've talked to them, it has not evolved into something legal action being taken, but we felt much more ready and prepared. So I'm a big believer in calling risk management if it even crosses your mind.
Great. Ian, the next question is for you. How do you balance as a new attending over the last 3 years between kind of being transparent with families when they ask you how many procedures have you done, being transparent about when you're going to have senior colleagues help you, and what that looks like in your kind of preoperative counseling of the patients and their families?
I mean, to be honest, I think that the best thing to do is to be 100% honest about your experience and where you're at. When they ask me, I word things in a specific way that also highlight that I am in fact experienced managing the problem, not because but the fact that I'm young and starting out is not going to take away from their care. So, for example, I'll give examples of how many lobectomies I do per month since I've been in practice, how many I have done already, what my outcomes are. But I do say, you know, I have been doing this. If they ask specifically, how long have you been in attending? I say, you know, this is my 3rd year in practice, but you know, like I do this a lot. This is all I do. I live and breathe lung cancer. I kind of like specify it that way. And if I have a specific case that's particularly complicated, then I tell the patient that this is a really tricky situation. It's an uncommon process that we don't see every day. And for that reason, I'm going to seek some support from my colleagues so it'll be like a 2-person or 2-surgeon procedure. And I introduce them to my partner, whoever is helping me in that case, so that they build a relationship with them as well. And then they feel like the team is helping with the case and not only me.
That's great. For Dr. Martin, you know, the first year of being attending can be very stressful for people, and there's a big magnifying glass. As a chief, you know, how do you balance being present and supporting, you know, your juniors versus giving them space and autonomy? And is there ever a time when you feel a need that you need to step in and kind of, you know, help redirect or help them with certain procedures or help them with outcomes to help them avoid having, you know, unintended consequences of just the learning curve?
Yeah, it's a great question. My own personal experience, the 2 people I brought on board after I became chief were already quite experienced. And so I wasn't sure if I brought in someone straight out of training. I was very much prepared to be there to lean on much more. But because I have partners that are already quite experienced, it hasn't been an issue. But I would say, hypothetically, if I had someone who is fresh out of training, I do think that's really important. There's a balance between being there and being supportive, and also letting that person feel that they have autonomy, that they can do it themselves, that help them build their confidence. But just being sort of a person to bounce ideas off of, talk about case strategies, being around to come in. And I know some of my colleagues will sometimes just in a very polite and kind way sort of meander into the room when their younger partner's doing a tough case and just say, hey, how's it going? Do you want me to scrub in, or do you need a hand, in a way that is not threatening or sort of insulting in any way. So, you know, those are some strategies that I've heard have worked well for people and help them grow and progress and let them build their confidence.
I'll second that, because I've done that in the past. And like Friday afternoons, I'll call my junior partner and just make sure they're doing okay. You know, it's 5 o'clock. I'm happy to, you know, pop in, try to get you out early if you want. So I think just being around, but not being too intrusive. That's just what Linda said. You know, I think it's, you know, you always worry that you're, you know, they think that you're just looking over their shoulder. But, you know, I think if you do it enough, I wander around, like even in the cardiac rooms, just to see what's going on. And so, you know, if you do that with some frequency, and people say, oh, they're just doing it just to be friendly and just to see what's going on, and, you know, not looking over people's shoulders to, you know, pick on them. So
I would say another strategy there that I try to employ is, I've been doing this almost 20 years now, but I have no problem at all calling a colleague in to take a look at a case when I think it's either unresectable or something's more difficult. And I like to try to set the precedent and example that it's okay to ask for help and it's not a sign of weakness. And I think if you show that as a senior or more experienced surgeon, then it makes the culture okay to do that when you're a younger surgeon.
Yeah, I second that comment. I think when I started working here, like my partner, there's 3 of us now, but we used to be 2 during my first 2 years, and he would call me for questions all the time. So it made me feel like they valued my opinion, but it also made me feel safe to ask for an opinion if I ever needed one. So I thought that was really good.
Being in a position where you're in leadership for your sections, I guess for Dr. Yang and Dr. Martin, what would your response be if you noticed that one of your partners was having outcomes that aren't as good as maybe you think they should be, or you notice some deficiencies? How do you how do you intervene in those situations when maybe they don't have the insight?
Steve, you want to take that one?
Oh, geez, thanks. Well, it's sort of like a mini M&M. Just sort of how would you do things different? You know, if you, like particularly like robotic approaches, I sort of let the junior folks, do what they want to do. Everybody puts their ports different and they struggle a little bit. So, well, okay, so, what did you learn this time? Do you want to, you change your approaches? So, I don't grill them. We just talk about it, like, how would you do things a little bit differently next time? Bad outcomes are usually presented at our M&M conference. But again, I try not to be too adversarial about it. You want people to learn. I learn too, because I always like seeing how other people do it, and we compare notes. So just like what Linda and Ian said, I go in there just to see how other folks set things up, because I certainly don't know it all.
Yeah, I'd say it's a challenging situation, and one strategy I've been employing in the last couple of years is, instead of being the Monday morning quarterback and going, oh, why didn't you do this? We started a Friday morning conference where we meet and review all the upcoming cases for the week and talk about what we're planning to do and why we're doing it. And I think that is a perfect opportunity to say, hey, what do you think about this? Or what do you want to try this? Or what are you going to do if X, Y, or Z comes up or happens? And to try to be proactive about it and hopefully avoid the need to be the Monday morning quarterback afterwards. Obviously, that's not going to work every time, but I feel like that's created, again, a bit of a culture of safety where we can collaborate and talk about things beforehand instead of going back and sort of judging after the fact.
Yeah, we do the same, and I find it really helpful. The residents love it because they get to discuss the indication of the case and all on the potential pitfalls, but you learn maybe certain things that potentially institutional, whatever situation you may encounter that the other surgeon encountered, that you kind of learn through them. So yeah, I think that's really valuable too.
And sometimes this stuff comes up like, oh, I need to use this, I might use this mesh, etc. Oh, do you know you got to call and order that 3 days ahead?
Exactly. They're like, oh, we don't. I tried using it last week and we have none. And yeah, that's
yeah.
We're just about out of time, but maybe one more really quick question. How do you guys feel that we can do a better job of preparing trainees for that shift and kind of the added responsibility and stress of going from doing a case as a resident or fellow to doing cases and carrying responsibilities with an attending?
I think that from my experience, which is shorter than everyone else's, I will say that one thing that I think made a lot of difference for me is to see my attendings when I was a fellow lead by example, in the sense that they were taking care of themselves. Like because you can talk about wellness and whether we take care of each other and yada yada, but if you don't walk the walk, it's hard for that to permeate. And having seen people take care of themselves through practice and still be a good surgeon and keep tackling difficult cases kind of taught me how to do the same. And I think that's really important to be involved in those conversations, for your attending to tell you as a trainee, like, I am really sad about this case, like this happened, and I all that interaction is really helpful for the trainee.
Yeah, I think that gets to your Brene Brown quotes about vulnerability, and showing vulnerability can be such a valuable lesson. I mean, in some respects, it's going from fellow to attending. It's the getting kicked out of the nest and you got to fly. And there's only so much you can prepare for that. And different people are going to handle it differently. Maybe are going to externally show their stress, and some are going to internally internalize it. But yeah, it's just a transition that has to happen, and it's always going to be a little bit painful.
I'll say, I mean, when you're in training, just see as much as you can. You may not be scrubbing every case, but go watch cases. In fact, as I said, when I have a difficult case, I ask my junior partner to come in and then say, this is going to be you one day, so I want you to come in and watch, or even scrubs. I'll have them scrub parts of the operation, and just much like a fellow, let them increasingly do more and more of the difficult part of the operation. So pretty much keep the sort of like this still the training.
That's great. Well, I think we're out of time, so I'm going to pass it off back to Beth. And I thank again everybody for being on the panel and for the talks and for the STS Education Task Force for all the work in putting this together.
Thank you to our moderator, Dr. Hobbs, and to our speakers, Dr. Bostock, Dr. Yang, and Dr. Martin, for your participation and insight. And thank you to Dr. Mitzman, Chair of the STS Education Task Force. Save the date for our next early career webinar, The Business of Medicine, Transitioning from Training to Practice, on Thursday, December 7th at 7 p.m. Eastern Time. Registration for the 2024 STS annual meeting has just opened, and we invite you all to attend. STS Surgeon members receive a discount, while STS resident fellow members can register for free. Learn more at sts.org/annual meeting. Thank you for participating and have a wonderful evening.